So, welcome to the podcast today. We will talk about local anesthetics. Um, and the few things we will discuss are uptake and mechanism of action of local anesthetics, their pharmacokinetics and pharmacodynamics, and then the toxicity. That's what is most relevant for the boards. So, first of all, let's talk about the mechanism of action of local anesthetics. So, how do they work? So, to understand the mechanism of action of local anesthetics, we have to first understand the basic nerve physiology. So, this is, let's say, hypothetical nerve fiber. As you can see, this is a cell membrane of a nerve fiber, and then this is something called the lipid membrane that covers the nerve cell membrane. So, this is a lipid bilayer of a nerve cell, and let's say this is an intracellular space. Oh, sorry, this is intracellular space, and this is an extracellular space or compartment. In the cell, as you know, that there's a lot of potassium, lots of potassium in the cell. The potassium concentration inside the cell is about 100 times more than the potassium concentration outside the cell. So if outside is 4 millimole per liter, sorry, per deciliter, inside the cell has something like 400 millimole by deciliter. And about sodium, there's more sodium outside the cell. This is opposite to potassium, and less sodium in the cell. Excuse me. And then the cell membrane has channels. I will highlight the channels in red. This cell membrane has channels, and these channels let the ketones, anions, and a lot of chemicals to cross the cell membrane in either direction. So some channels are unidirectional. They only let the chemicals or anions, ketones to pass from extracellular space to intracellular space or vice versa, and some channels can be bidirectional. There's one thing important about the channels. Okay, if this is a channel in the cell membrane, which we discussed is a lipid bilayer surrounded by a fatty membrane. If this is a channel, this channel is usually for a simplicity, like channels can be complicated and they can have a very complex structure. But for simplicity, I mean, this is not the physiology class. So just to simplify the things, channel has a gate. Could be, let's say this is a gate, or this is a gate. So channel had gates, and sometimes the channels are closed. And channels open up when they are stimulated. So either they are stimulated by something called ligands, different kind of chemicals or drugs that can bind to these channels and open the channels, or they can be stimulated by electrical impulse that is called voltage. So either the channels can be the ligand gated channels, that when they operate on binding to a particular ligand or a drug, or they're voltage gated channels, that's when they operate when the electrical signal arrives or there's a change in a potential difference across the membrane, one and the same thing. So we will talk about voltage gated channels here. Okay, recapping this, combining what we discussed in a previous slide, this is again a lipid membrane of a nerve cell. simplified again, oversimplified, oversimplified. Okay, lots of potassium inside. Oops, lots of potassium inside. Some sodium inside. Lots of sodium outside. Takes more time to write sodium than actually making the slide. So lots of sodium outside the cell. And then channels invaginating the membrane through and through. And at resting stage, the channel is more, the cell is more negative inside. The potential difference across a nerve cell is about minus 60 millivolts at rest. That's a potential, that's called a resting membrane potential. I'm not going to write resting membrane potential, but RMP is about minus 60 millivolts. So inside is more negative as compared to outside. This is because of there's a lot of negatively charged proteins inside the cell. Let's say, what color do you like for negatively charged proteins? Maybe brown color. So there's a lot of negatively charged proteins inside the cell. So what happens is that if you look at this, if you go to basic physiology, potassium, because of its concentration gradient, tries to move out of the cell. However, these negatively charged proteins, they are big protein molecules and they are negatively charged. So they cannot cross the lipid membrane freely. So they have to stay in. They keep that potassium inside the cell. So potassium tries to move outside the cell by virtue of its concentration gradient. Let's say concentration gradient. However, these negatively charged big molecules of protein tend to keep potassium inside because of something called electrochemical gradient. So there is a lot of potassium inside, but still there's some potassium that leaves the cell, and so there is more negative charge inside the cell. This is why the cell has a negative potential that's minus 60 millivolts. So I'm not going into details because it can take all day to explain this. But if you really want to discuss this in detail, then you can consult a physiology textbook on the cell physiology. So anyways, what we discussed so far on about the nerve cell is, number one, there's excess potassium intracellularly. There's excess sodium extracellular. Okay, and the resting membrane potential is net negative inside the cell because of the negatively charged proteins, and the excess sodium, which I will discuss this, I didn't mention it before, the excess sodium that's outside the cell cannot go inside the cell because the lipid bilayer is impermeable to sodium. So this lipid bilayer is impermeable to sodium. Lipid membrane, impermeable. That is, it's like a wall, brick wall to sodium. So sodium from extracellular space cannot go intracellularly in a resting state. Now, let's talk about the cell membrane again. It's a very important concept and you have to understand this because of sodium channels and in order to understand the mechanism of action. Okay, so this is a lipid bilayer, and let's have the sodium channels here. And let's say this is extracellular, and let's say this is intracellular. So what we discussed is that there's a lot of sodium outside. Okay? And in a resting state, sodium cannot enter in the cell, cannot go in the cell. However, these sodium channels, let's say this is sodium channel, they can open up in certain situations or circumstances, and then they can let this sodium from extracellular space to go in the cell. And when these channels open up, sodium just gushes in because of its concentration gradient and also because of the electrochemical gradient. Because remember, inside the cell is more negative as compared to outside. So there will be two forces that drive the sodium in: concentration gradient and electrochemical gradient. So sodium is just waiting outside. So now we will talk about certain type of channels. Again, lipid layer. Let's do this. Let's make a nice coat of lipid on the cell membrane. And let's take one single channel. Sorry, this is one single channel, sodium channel. Okay. Now if you look at the sodium channel, it's closed at a resting membrane potential. That's when the cell is resting. Well, cell is never resting in a way that there's always some basal energy expenditure. But at a resting membrane potential, these sodium channels are closed. So they have actually, let me just simplify this. So these sodium channels have two gates. Gate like a gate which opens the channel. Gate. Let's make one gate here, another gate here. And let's call this gate as activation gate. So they have two gates, activation gate, and inside the cell there's a gate called inactivation gate. So there are two hinges on the channel, which is like a pole. When this channel is stimulated by something called electrical impulse, or you can also say voltage. So these channels are voltage gated sodium channels. They might ask you what kind of channels are responsible for action of the local anesthetics. The answer is voltage gated sodium channels on the most part. So when there's a change in action potential or there's an electrical impulse that arrives, the activation gate opens up, it opens up. And when activation gate opens up, the sodium that's waiting outside just gushes into the cell. So there's an influx of sodium. Let's use a technical term called influx of sodium ions into the cell through a voltage gated sodium channel, which is opened by a change in voltage or arrival of an electrical impulse. Okay, so all this sodium goes in the cell. And what happens to the cell when the positively charged ion goes in the cell? So it becomes positive. So the action potential changes from minus 60 millivolts to, I would say, about 35 millivolts, depending on the book you read, because of the sodium, net influx of the positive charge. So this happens in stages. These stages are, again, you have to, recap your nerve physiology. This happens in stages. Oh, I have this. Let me use this. Okay, so this is two-dimensional graph, and what I'm going to draw here is a nerve action potential so that you understand this better. Okay, so as we said, the nerve at resting membrane potential of a nerve is, about minus 60 millivolts. We explained why. Let's make this 0. Let's make it plus 60. Okay. So here, let's use another color. Okay. So here what happens is sodium channels open up. Because of an electrical impulse. And what happens to the membrane potential? It becomes more positive. It goes up and up and up and up and up and up and up, and then suddenly fast. And then there is an action potential. This is about, say, about 30 millivolt, 35 millivolt. There's an action potential. Now, certain things here I would like to mention are, initially what happens is when the sodium channels open up, the membrane potential goes up and up and up, becomes positive. At a certain stage, it just shoots up like a spike. This point is called, we all know what this point is called, threshold potential. Threshold potential. And threshold potential is a membrane potential at which action potential is inevitable. And net inward current becomes larger than net outward current, and depolarization becomes inevitable, and there's an upstroke. And then there's an action potential here. So there's a rapid depolarization. So this is all because of one culprit. I'm talking about nerve cell, sodium ion. Where? Voltage-gated sodium channel. Voltage-gated sodium channel. Not a very good contrast, but I hope you can see this. Okay. And then what happens is something else after the action potential. Let's go back to that channel. We discussed that this channel gate opens up. So this channel gate opened up, which is activation gate. So deep depolarization also does another thing. It closes the inactivation gate. Now this is very, very important. Inactivation gate, deactivation gate, inactivation gate. So this is closed. So more sodium cannot go in anymore. So sodium conductance stops. Now at this stage what happens is, as we discussed, there's another ion here called potassium, right? Okay, at this stage, potassium, so sodium conduction is almost nil at this point because of closing of a deactivation gate. However, the potassium conductance is still happening. So potassium, there's a high potassium inside the cell. And remember we mentioned what was keeping the potassium inside the cell? It was the negatively charged proteins. But now you have enough sodium inside the cell to neutralize those proteins. So there's nothing to hold the potassium back. So this potassium diffuses out and repolarizes the membrane. So this potassium has repolarized the membrane and brings the membrane back to its resting membrane potential, actually slightly lower. This is what I will discuss. Otherwise, I will go deep and deep into this physiology. And then, as you all know, what happens after this, there's something called sodium potassium ATPase that restores the sodium potassium concentration in the cell. So, most important take home message. Sodium channel. Okay? Has two gates. Gate 1 and gate 2. This is called activation gate. And this is called inactivation gate. Change in voltage or action potential opens up the activation gate and causes the net inflow of the sodium. And at the same time closes the inactivation gate, so that there's a transient influx of sodium which stops after a certain millisecond because of closure of an inactivation gate. So this is it. Now, how do local anesthetics work? Finally coming to the mechanism of action of local anesthetics. Now I have to go back to this lipid bilayer. I have to draw this fat here. And I have to also label extracellular, intracellular. Then I have to draw a big channel with activation gate and inactivation gate. So local anesthetics, actually, let's have this as a local anesthetic. Local anesthetic molecule, let's say this is a local anesthetic molecule. It dissolves in the lipid bilayer, crosses it by the simple diffusion. And now, simple diffusion, there's no channels for local anesthetics. They are lipid-soluble molecules. Okay, so it crosses the lipid bilayer, goes from extracellular space to intracellular space, and then binds to this. What is this? Inactivation gate. Inactivation gate. And closes it like this. So inactivation gate is closed. So sodium current stops. It binds to an inactivation gate and actually keeps it in a closed in a closed state. Sorry, I take it back. I was wrong. I go back 20 seconds. I don't want to edit the video. When I said that it diffuses in the cell, it binds to the inactivation gate and keeps it in the closed state. It doesn't actually close the gate itself, but if gate is already closed, it will keep the gate closed. So a next electrical impulse will not cause the opening of the sodium channels, and transmission would stop. It kind of locks the gate in an activated state. So as you can see, any channel whose activation gate has opened and inactivation gate has closed, if binds to a local anesthetic molecule, it will stay closed because of closure of inactivation gate. This is the reason why they stop the nerve signal propagation. Now, something else I will like to mention here. They cross the lipid membrane because they are lipid soluble. Once inside the membrane, inside the cell, the pH and everything changes. So they become charged. So they actually ionize in the cell. They become positively charged inside the cell because of they get ionized in the cell intracellularly. So this is how they work. Mechanism of action. Now, if you forget everything, you have to remember number one in mechanism of action. What they do, they bind, attach to sodium channels. Okay. If you try to be smarter, you can say voltage gated sodium channels. Intracellularly, that's even smarter. And to what? To inactivation gate. And do what? Keep the inactivated gate in an inactivated state. Prevent it from opening. So keep the channel inactivated. Okay. So prevent the nerve transmission, not a rocket science. And as you can see from this statement, that they will avidly bind to channels that are activated. Because when channels are activated, after a few milliseconds, their inactivated doors are closed. So avidly binds to activated channels. Okay, that is a mechanism of action of sodium channels. And for brownie points, they diffuse in the cell because they are lipid soluble. So they are lipid soluble, so they diffuse inside the cell and become positively charged and then attach to sodium channel. Oh, I forgot to mention voltage gated sodium channel. Now, if you remember this, I think you can answer most of the questions on mechanism of action. Thank God, that's done. A lot of work. Okay, now they also say uptake. So different anesthetics have, local anesthetics have different pharmacokinetic properties. So we will go to the next step now and talk about compare and contrast the individual local anesthetics. So for that, first of all, what are the local anesthetics chemically? Now we're going to only talk about local anesthetics, not about the cell physiology. So what are the local anesthetics? So local anesthetics are essentially chemicals that are weak bases. And weak bases, as you know, are proton acceptors or hydroxyline donors. I'm not going to mention that, but so there are two groups of local anesthetics. One group is called amide, and another group is called ester. From your chemistry, you remember what amide is and what ester is. Ester has an ester linkage, and amide has an amide group attached. So the examples of the amides are, like, let's say the amide group would be, as you know, nitrogen, CO, and esters have ester linkage. So examples of amides are most commonly used local anesthetic, lidocaine, yay. Also, another widely used local anesthetic, bupivacaine. Another widely used local anesthetic, ropivacaine. Another widely used local anesthetic, not widely used local anesthetic, prilocaine, cane. And if you ever heard of succinylcholine apnea, you would be familiar with a name called dibucaine, dibucaine. Okay, and then what are the common esters? Esters are procaine, uh, cocaine, cocaine, ametocaine. Now also chloroprocaine, and I'm sure somebody has already taught you this. If you have two eyes, you're amide. If you have one eye, you're ester. Prove me if I'm wrong. I think that's a rule. So anyways, now you know what the local anesthetics are classified into two broad categories, amides and esters, depending on their chemical structure. And amides more or less are metabolized by very similar pathways, and esters are more or less metabolized by very similar pathways, different from amide. Okay, so coming back to the individual local anesthetics. So, uh, which local anesthetic class would be more stable, if you think? Amides would be stable because they don't have a fragile ester link. Well, esters will have a short half-life because of the ester group, which can be hydrolyzed relatively easily. Everything is relatively easy. Nothing is easy. So now we're going to talk about something very important, very commonly asked in the boards. Very commonly asked in the boards, I think. Only thing asked in the boards. The physiochemical properties. First of all, potency. How potent the drug is. I don't have to define what potency is in this lecture. You should know what potency is. Highly potent drugs, you need less dose. Less potent drugs, you need more dose to produce or elicit a same clinical effect. So potency is directly proportional to lipid solubility. Because remember, in order to act, the local anesthetics have to cross the lipid bilayer. So more lipid soluble means they can cross the cell membrane easily. More molecules can cross the cell membrane more easily, and more molecules are available to bind to those inactivation gates. So potency is directly proportional to the lipid solubility. Very less lipid soluble local anesthetics would not cross the lipid bilayer and hence not available to bind to the inactivation gates. So let me give you some examples about the lipid solubility of the local anesthetics. So for example, lipid solubility of lidocaine, if we call the lipid solubility of lidocaine 150, just on some scale, if it's 150, that of bupivacaine would be 1000. So bupivacaine's lipid solubility on the same scale would be 1000. So it is about what? 7-8 times more lipid soluble than lidocaine, right? So same thing. Like, so bupivacaine 1 milligram probably equals to 4 milligrams of lidocaine. So it is more potent than lidocaine. So that's understandable based on the lipid solubility. And I don't want to give you more examples, but this would be the question asked. Potency is lipid solubility. It can be twisted in a way that, okay, this drug is more lipid soluble, or so what is an expected dose, vice versa. Okay, do not forget this, because this is something always asked. And you know now why, because more molecules are available to cross that lipid membrane. Now, second property is what they call potency, is we discussed. So the second property is duration of action. Duration of action. How long does anesthetic last? Duration of action. Now, it's protein binding. Duration of action is directly proportional to protein binding. Protein binding. So if you have molecules of local anesthetic, and these are the, where's the brown color? Yeah. And you have molecules of protein, and they attach this local anesthetics, they would not let them escape or run away. So duration of action would be prolonged. Higher the protein binding, longer is the duration of action. Then I'm gonna go to onset of action. How fast, quickly the local anesthetic works. A little bit complicated now. The onset of action is related to something called P. Let me choose a black color. Yes, P K A. So local anesthetics I discussed earlier are weak bases. And if you dissolve them in water, they are predominantly ionized. So what is a pKa? pKa is a pH at which a particular chemical exists 50% in ionized form and 50% in unionized form. So if my pKa is, let's say, if I'm a chemical, and my pKa is 6, that means at pH 6, half of me would be ionized and half of me would be unionized. Then you have to, obviously, these things, if you go to the chemistry lessons, provided other things being constant, such as temperature, blah, blah, blah. Okay, so pKa is a pH at a given temperature where a drug exists 50% in ionized form and 50% in unionized form. If you're a chemist, it doesn't have to be drug, chemical. Okay, I hope you understand that. And local anesthetics are weak bases. So that means that higher pKa, if some local anesthetic has higher pKa, that means more of it is ionized. That means more of it is ionized. This is because they are weak bases. If it's a weak acid, it turns around, becomes other way around. So for weak bases, higher pKa means higher ionized fraction. And lower pKa means very complicated, right? Lower pKa means less ionized, higher unionized fraction. That's only for weak bases. Now I can write an equation and try to explain you this, but that's going to take another 30 minutes. And this lecture is already taking too long. Okay, so let's give you an example. If some chemical has a pKa of 7, having said that, if some weak base has a pKa of 7, another weak base has a pKa of 8, right? pKa of 8 would have higher ionized fraction than unionized fraction. And this would have relatively, compared to number 8, less ionized, more unionized fraction. Now, how does that matter? Why does that matter? So it means higher pKa, more ionized, less available to penetrate a lipid membrane. Because ionized molecules do not penetrate the lipid membrane. They need channels for that. They cannot just diffuse, dissolve and diffuse. So what effectively it means is that higher pKa results in higher ionized fraction of a drug. And that ionized drug, more ionized drug is, less it crosses the lipid membrane. And so, less drug available to cross lipid membrane. And hence, onset of action is slower. Does it make sense? So, lower pKa, higher onset of action. Take home message. If you understand nothing of this, just these two things. Low pKa, faster onset of action. High pKa, slower onset of action. Make sense? That's only for local anesthetics because they are weak bases. Now if you try to memorize that, then I would give you an example. Let's say go back to our favorite local anesthetic called bupivacaine and lidocaine. So which one has a faster onset of action? So lidocaine has a faster onset of action. So its pKa is 7.9 and bupivacaine has slower onset. Its pKa is 8.1. You can see higher the pKa, slower is the onset. More time it takes to act. So or you can say higher the pKa, higher is the time, lower the pKa, lower is the time. Lower time means faster onset of action. Then they love to ask something else here. They love to ask you about a drug called chloroprocaine for whatever reason. Chloroprocaine. Every single exam or test has a question on chloroprocaine. That why chloroprocaine is so fast and act like why the onset of action is so rapid, although its pKa would predict opposite. So the chloroprocaine is pKa is, and this is lidocaine pKa. See lidocaine here. This is bubicaine's pKa. So the as we know that lidocaine's pKa is 7.9, bupivicaine's pKa is 8.1, and the pKa of chloroprocaine is actually, top of my heart, I can't remember what pKa of chloroprocaine is, but what is it? Let me look it up. I just forgot. So chloroprocaine's pKa, now because I'm doing this, you would not forget this ever in your life. This question, you will always get it right if it's asked. But then again, it's not about answering the question right. So its pKa is 9. Okay. So 9, 7.9, 8.1. Remember I said higher the pKa, higher is the time it takes to act. But then this is the fastest acting local anesthetic. If you just go on pKa, it would be slowest acting local anesthetic. So what's going on here? Okay, what's going on here is chloroprocaine is not a very potent drug. You have to give lots of chloroprocaine to achieve that amount of block. So when you give initial dose of chloroprocaine, then because it's very low and it has a very low potency, you give lots of drug. So you give lots of drug because of its low potency, because of low potency. So you give a lot of drug because of its low potency. So you create a big concentration gradient, like a huge concentration gradient. And remember from Fick's law of diffusion that if you create a huge concentration gradient, let's say you give 100 here, 0 here, rate is faster. If you 10 here, 0 here, rate is slower. 5 here, 0 here, rate is even slower. So drugs that have low potency, you give a lot of drugs, and they're at time t is equal to 0, the concentration in the extracellular, in the blood is what you have given IV or whichever route, and concentration at the target site is 0. So low potency drugs, you give a lot of them, so there's an initial high concentration gradient. Less potent drugs, there's initially smaller concentration gradient. So low potency drugs in general have higher onset of action than the more potent drugs. That's why chloroprocaine, despite its high pKa, is faster in onset because of its lower potency. Does that make sense? It took me a long time to discuss that, but it's worth it. It's always asked. Okay, so let's go to the other effects like intrinsic vasodilator effects. So some local anesthetics are vasodilators and some are vasoconstrictors. Most importantly, cocaine is a drug that is a potent vasoconstrictor, and it's sometimes used instead of epinephrine, or it was used instead of epinephrine to constrict the blood vessels in the nasal mucosa. So that's about it. Now something interesting, if you have an infected tissue and you infiltrate that with local anesthetic, they don't generally give you very good local anesthesia. because infected tissue has a lot of acid, lactic acid and all that. And at acidic pH, uh, the weak bases are ionized more, so you have very little of local anesthetic left in an ionized state. So that's why they are ineffective to anesthetize the infected tissue. Okay, so far, let's summarize what we learned. If you forget everything, just remember this. Remember, first thing we discussed, potency. Potency is directly proportional to, oh, what happened to that? Potency is directly proportional to lipid solubility. Second thing, onset of action is, say, inversely proportional to pKa. Faster onset of action if you have low pKa. And third thing we discussed was the potency, onset of action, and duration of action. That is dependent on protein binding. And one exception to rule 2 is chloroprocaine. Exception. Chloroprocaine, because of its low potency. You have to give a lot of it, so you create a higher initial concentration gradient. Okay. Now let's move on and let's talk about the pharmacodynamic effects of these drugs. Okay, so let's talk about what they do to the body. First of all, what do they do to heart, cardiac? Now, it's interesting that there is a local anesthetic, lidocaine, that is used to or may be used to treat cardiac arrhythmias. So bupivacaine is not used to treat cardiac arrhythmias, but lidocaine is. The lidocaine is used because of its shorter time of binding to the inactivation gates. So it dissociates from the sodium channel very quickly. So it's not that toxic. However, the bupivacaine stays attached to that sodium channel, so it's toxic, because if it keeps on sticking to that sodium channel, keeping it in a deactivation state, then it would slow down or stop conduction for a long period of time, and it can cause heart blocks. So just that's why its affinity for that's the word, yeah. So its affinity for sodium channels is high and keeps and stays attached for a longer time. For a longer time, so it's not used as a bupi. Excuse me for my handwriting. So it's not used for as a antiarrhythmic. So it's about 10 times, its affinity is about 10 times that of lidocaine. So what else? So in the toxic doses, local anesthetics can attach to the cardiac tissue, slow down the conduction, and may cause reentrant tachycardias, life-threatening arrhythmias, cardiac toxicity, and longer-acting local anesthetics can cause a persistent depression. And in the late stages, you can have a complete heart block and ventricular fibrillation. What happens to the central nervous system? So look, that also has nerve cells, right? So local anesthetics, they can go to the brain and can have a biphasic response. That's what's asked in the tests. Initially, they call excitation. So initially, they call excitation. That means that they inhibit the inhibitory neurons. So that's why they call excitation. So first phase is in CNS is CNS excitation. So you have a visual disturbances, you have tingling, circumaural tingling, you have visual disturbances, tremors, and dizziness, and then convulsions. So CNS excitation, so tingling, visual, but then subsequently you have depression, which can lead to coma, apnea, and death. Okay, that's the two main things in the central. I mean, in the local anesthetics. So the question is, what happens first if you reach or you cross the the toxic limits of the local anesthetic? What happens first? Do you have CNS toxicity first, or do you have a cardiac toxicity first? So obviously you will have a CNS toxicity first because that has more of a nerve cells. That's the right alley for these local anesthetics. And then you have a cardiac signs of cardiac toxicity. That is always also sometimes asked. So in a awake patient, the first thing you see is neurological symptoms before you see the cardiac symptoms. Because local anesthetics first work on the nerve cells. We spent an hour on that. So they will first go and attack central nervous system. So you will have these tingling, visual disturbances, and then you would have what we call it, the cardiac arrhythmias. Okay, now let's go to the classical pharmacokinetics of local anesthetics. So first of all, in classical pharmacokinetics, we always talk about absorption. Local anesthetics can be administered by multiple ways. I don't know if I will cover all those, but yeah, you can give them infiltration. You can administer them like that's like local infiltration, or nerve block, like inject near the nerve, like femoral nerve block, or brachial plexus nerve blocks. You can give them like subcutaneous, which is infiltration. You can also give them IV, like some people give lidocaine IV. Most people can give lidocaine IV to as an antiarrhythmic or to blunt the response to endotracheal intubation. Or these days, there's a research going on analgesic properties of lidocaine. And then you can also give local anesthetic epidurally, intrathecally, cardly. So all these routes are different routes. So what happens is that also I would say, sorry, before that, I will also mention something else. Least but not the last. No, last but not the least. Remember this. When I say this, I have a good intention. When I try to puzzle myself, see what I'm trying to do is I'm trying you guys to think and not forget. Intercostal. Last but not the least, or least but not the last. So wherever I just Repeat myself, that's something which is important. So if you give a single dose of local anesthetic through all these routes, the question asked is, highest bioavailability is achieved by intercostal route, then second is caudal, then epidural, then you have a brachial plexus, then you have subcutaneous. Now I say bioavailability, someone might say bioavailability is the concentration at the target site. Let me correct myself. If there's some pharmacologist watching this, highest plasma concentration is achieved if you give the same amount or dose through intercostal route, then caudal, then epidural, then brachial plexus, then subcutaneous. So signs of toxicity, chances of toxicity are higher by an epidural route than with caudal and intercostal, then caudal, epidural, brachial plexus, and subcutaneous. So you can say ICE. What do you do with BS? Okay, so ICE BS. Okie dokie, that's something. Now local anesthetics, also where you give local anesthetic, just use the common sense. If you inject it in a vertebral artery, that has more chances of toxicity than if you inject in my dorsalis pedis artery. So route and site of administration are important. Also dose. So toxicity of a local anesthetic. If you forget everything, remember, it's dependent on dose. Obviously, if you give high dose, more chances of toxicity. Route, ICE BS, remember? This is easy to remember. ICE, then remember BS too. Dose, route, and site. Okay. Now something I would just mention is the common sense. If you inject it intravenously, that means that has achieved highest plasma concentration, right? So before ICBS, just remember, if you injected IA or intraarterial or intravenous, that has most chances of toxicity. Then other routes you can remember using ICBS. So if I ask you a question, same dose of local anesthetic injected through intercostal, caudal, epidural, and IV, what would have most deleterious effect, or can have, or may have, or might have? IV, then intercostal, then caudal, then epidural. Okay, next thing is distribution. So local anesthetics are actually, when administered, they can bind to proteins. Esters not so much, but amides are really, they stick to the alpha-1 glycoprotein. So distribution, they can bind to alpha-1 glycoprotein amides. And also albumin too. So when you have states of high protein binding, such as when you have a lot of protein in your blood, such as in pregnancy, the free fraction of the drug is reduced. And when you're malnourished, the free fraction of drug would be increased. And then what happens to, like talking about the pregnancy, and we give them local anesthetics all the time for spinal and for epidural. So which is more what crosses placenta more, bupivacaine or lidocaine? So lidocaine is not so much uh, protein bound, so it does, the free fraction is higher than bupivacaine. So lidocaine crosses placenta more. So lidocaine crosses placenta more than bupivacaine. Just remember that. And when inside the fetus, because fetus has low pH, as you know, or you should know, the lidocaine becomes ionized and is trapped. That's called ion trapping. That's sometimes asked too. Next is metabolism. Very important. How are these drugs metabolized? So esters are hydrolyzed because they have ester link that can be easily hydrolyzed by enzymes called plasma cholinesterases. Plasma cholinesterases. Does it ring a bell? Plasma cholinesterase. It's the same enzyme that metabolizes what? Succinylcholine. So one of the metabolites of ester metabolism is PABA. PABA is para-aminobenzoic acid, and it can cause allergic reactions. So not all esters are hydrolyzed. Cocaine is actually in plasma. Cocaine is hydrolyzed in liver, so it doesn't give PABA. But other esters, they can give PABA, and that PABA can cause allergic reaction. Remember for your test, or just remember. Then what happens to amides? Let's use a black pen here now. Amides undergo hepatic metabolism by an enzyme called amidases, whichever way you want to say, in liver. And metabolism is slower than the esters. So what happens in liver failure? You have increase in half-life of amides. That can be a question that can be asked. Okay, now let's talk about, we were talking about toxicity. So most of these drugs have some toxic doses. So I'm going to talk about the toxic doses of lidocaine. So what lidocaine's toxic doses, how much lidocaine you should give or you should not give. So the lidocaine's toxic plasma concentration, the plasma concentration at which lidocaine exhibits toxicity is about more than 5 microgram per cc. And they say that it's 3 milligram per kilogram body weight without epinephrine, and 6 to 7 milligram per kilo with epinephrine. Now this is different in different books, but that's what they give you. They give you a range. And bupivacaine's toxic doses, BPV is 1 to 1.5 milligram per kilogram. Excuse me. So I've talked a lot, huh? It's very important topic. So I asked a lot, tested a lot. So other things are I will mention is, we mentioned metabolism. Now we talked like few lines about each local anesthetic. I think that should be completing our discussion. Lidocaine. Few important points about lidocaine are, so lidocaine, the indications are local anesthesia, and also it can be used as an antiarrhythmic, and it is used to blunt the response to endotracheal intubation And also, there's a new research that intravenously it can also act as an analgesic. But don't take my word for the fourth indication. Go and read about it. And it's formulated as lidocaine hydrochloride. And you must have seen lidocaine given IV infiltration or spray. A lot of people use it as a spray for awake fiber optic. And again, it's metabolized by liver, and I told you the toxic doses. Then we go to another drug called bupivacaine. So bupivacaine is usually, commonly used as an epidural or as a spinal, and also used for nerve blocks. It's an intermediate to slow-acting local anesthetic. It's toxic local anesthetic. It's also metabolized by liver. Then you have an isomer of bupivacaine called levobupivacaine. I haven't seen that in the United States, but I've used that elsewhere. Uh, so the single advantage is that it has a potential for reduced toxicity. I don't think there's a good evidence for that. Then you have ropivacaine. And it also has a improved toxic profile. And some people say that um, it causes reduced penetration of the large motor fiber, so it causes less motor block. So then you have, I think we discussed most of them. You can read about these drugs. Now let's see what else they want us to discuss. So we discussed so far uptake, biotransformation, excretion, comparison of drugs and chemical groups, prolongation of action. Yeah, prolongation of action. That's something we can discuss. Prolongation of action. So you can prolong an action of a local anesthetic by either adding epinephrine, that causes vasoconstriction and hence decreases the clearance of the local anesthetic from the target site. Usually 1 in 200,000 epinephrine is added. And then you can also prolong the action by adding bicarbonate. So what bicarbonate would do is addition of bicarbonate would increase the pH, not a rocket science, increase the pH of a local anesthetic formulation and hence increase the unionized fraction. My spellings. So what it does actually is it doesn't prolong the action, but actually it makes it faster onset. I thought it was worth mentioning. So faster onset by use of bicarbonate and prolonging the action with use of epinephrine. So sometimes you see that epidural top-ups used in OB. Some clinicians put some epinephrine and also add bicarb so that faster onset by bicarb and prolonged action by epinephrine. Now, my discussion wouldn't be complete if I don't discuss the few other things such as toxicity. We discussed the toxic doses, but what happens during toxicity? You can have CNS toxicity first, and then you can have a cardiovascular toxicity, which can cause a cardiac arrest. So if you have signs of toxicity, there's a drug called intralipid. Intralipid is a lipid that binds to the local anesthetics molecule. So it's one-to-one binding of intralipid to a local anesthetic molecule, and this complex is inactive. So intralipid is actually what's the word? Sink for a local anesthetic. So any signs of local anesthetic toxicity, you can use intralipid. And if there's a cardiac arrest and you're doing CPR on a patient who had toxicity, you can use intralipid. That's one difference from ACLS, doing ACLS on another scenarios. That in this scenario, you can give intralipid. Then they also want to, and also one thing I would like to mention in this CPR. So use of intralipid, and also you need prolonged CPR. So if you have given bupivacaine to somebody and someone has cardiac arrest, you can give intralipid and also prolonged CPR because bupivacaine takes long time to dissociate from the sodium channels. So you have to keep on supporting the patient for that time. So CPR can go above 30 minutes sometimes. Hopefully that doesn't happen to you. Then there are other things they like to discuss, something like methemoglobinemia. Methemoglobinemia. So what is methemoglobinemia? Normally your hemoglobin is Fe positive positive, but if it becomes Fe positive positive positive, that is from ferrous to ferric, the iron in your hemoglobin, this hemoglobin is called methemoglobin. So, and it doesn't bind oxygen. So what can cause methemoglobin? Prilocaine can cause methemoglobin, which is an ester local anesthetic. No, it's not. It's two eyes, remember? Don't forget it. Whenever I do a mistake, that is like a must question in the boards. Prilocaine is what? Is an amide. So prilocaine is most rapidly metabolized amide local anesthetic. It can be metabolized at multiple sites, we said liver, but also kidneys, lungs, and it has a metabolite called toluidine. That O-toluidine can cause methemoglobinemia, which is it gives us useless hemoglobin. And you can treat methemoglobinemia with methylene blue. So now discussing the key points here about the toxicity. If you forget everything, do not forget this. Toxicity. If you have a patient who has a lipid toxic, who has local anesthetic toxicity, you have CNS signs first before CVS. Question asked. You can use intralipid, IV, and also if you have to do the CPR, it could be a prolonged CPR. Second thing, there's a local anesthetic called prilocaine, which is an ester, no, sorry, amide. Repeat it again. So prilocaine is an amide that can get metabolized to O-toluidine, which can cause methemoglobinemia. That is, this is methemoglobin. And the treatment is methylene blue. Okay. This happens more in neonates because neonates have reduced or very low level of methemoglobin reductase enzyme. So they are more prone to, children are more prone to methemoglobinemia. So yeah, I hope you like this lecture and let me know if there's some feedback, and I apologize for all the mistakes I made, but I hope this lecture was useful and I will try to touch more topics next time. Thank you.